Hello, dear friends. This is Dr. Abhishek, and I am present here to give a brief overview of subarachnoid hemorrhage. I have tried to keep the video as brief as possible without missing any major details that will help you learn the key pointers related to the concept. Now, let us have a quick recap of the meninges of the brain. As we all know, that meninges is the protective outer covering of the brain. It consists of three important layers. The outer one is the dura mater, then arachnoid matter, and then pia mater. Above the dura mater and between the skull is the epidural space, and below the dura mater and above the arachnoid matter is the subdural space. Then comes the subarachnoid space, which comes between the pia mater and the arachnoid matter, which holds the CSF. Dura mater consists of two layers, the internal layer and the external layer. The internal layer lies above the arachnoid matter and separated by the subdural space. Then external layer adheres to the inner layer of the skull. Now the two layers of the dura mater, the external layers and the internal layers, they lie close to each other and divide into meningeal folds which help divide the sections of the brain. As we all know that the fox cerebri, it divides the two cerebral hemispheres, and the tentorium cerebelli, which divide the cerebral hemispheres from the cerebellum below. This concept is important to understand the brain herniation, which occurs due to increased intracranial pressure. Now coming to the anatomy of the ventricles of the brain, as we all know that the two lateral ventricles drain into the third ventricle via the interventricular foramen or the foramen of Monro. Then this third ventricle via the cerebral aqueduct or aqueduct of Sylvius or Iter drains into the fourth ventricle. Then from the fourth ventricle via two lateral foramen of Luschka and one median foramen of Magendie, it drains into the subarachnoid space. Traumatic head injury is an important factor in subarachnoid hemorrhage. Falling on the bath and hitting your head is an important cause because the vessels in the subarachnoid space are unsupported and can break easily. A very important cause of subarachnoid hemorrhage is the rupture of the saccular or the berry aneurysm. Now, aneurysms in brain can be of multiple types, the most common of which are the saccular or the fusiform type, of which the most common is the saccular or the berry aneurysm, and they mostly arise from the anterior half of the circle of Willis. Genetic disorders like Marfan syndrome also predispose to aneurysms. Another important cause of subarachnoid hemorrhage is arteriovenous malformations in the brain. In arteriovenous malformation, there will be direct connection between an artery and a vein. So the blood will pass quickly from the artery to vein bypassing the normal capillary network. So because of this, the veins can rupture and can lead to hemorrhage. Coming to the clinical features of subarachnoid hemorrhage, it is characterized by a thunderclap headache. It's basically described as the worst headache of a patient's life, and it often peaks within seconds to minutes. Then in subarachnoid hemorrhage, blood will also irritate the meninges that will lead to meningeal signs. So this will lead to nuchal rigidity and neck stiffness, then photophobia or aversion to light, then positive Kernick sign and positive Brudzinski sign. In positive Kernick sign, the patient he lies supine with the hips and the knees flexed. So on extension of the knee, pain will occur. So that is positive Kernick sign. In Brudzinski sign, passive flexion of the neck causes involuntary flexion of the hips and the knees. So these are characteristic of meningeal signs. Now the increased intracranial pressure can also cause brain herniation, which can be broadly classified into two types. One is the supratentorial herniation, which occurs above the tentorium cerebelli, and another one is infratentorial herniation, which occurs below the tentorium cerebelli. Now, an important type of supratentorial herniation is the subfalcine or the cingulate herniation, which is the herniation of the cingulate gyrus below the falx cerebri. Since the frontal lobe is involved, it affects the areas supplied by the anterior cerebral artery, which can cause contralateral lower limb weakness and sensory loss. Another one is the uncal herniation, which is the herniation of the uncus in the temporal lobe below the tentorium cerebelli. It affects the area supplied by the posterior cerebral artery and the third cranial nerve, that is the oculomotor. So it causes down out blown pupils. Then tonsillar herniation, it is the herniation of the cerebellar tonsils downwards to the foramen magnum. Since it affects the brainstem area, so it can affect heart rate, respiration and consciousness. It can also lead to coma and death. Then upward cerebellar or transtentorial herniation, which is the herniation of the cerebellum above the tentorium cerebelli. It can lead to ataxia and nystagmus. Then central or transtentorial herniation, which is the herniation downwards towards the brainstem. It can lead to decorticate posturing and decerebrate posturing. In decorticate posturing, the arms are bent towards the center of the body, and in decerebrate posturing, the arms are straight and tense and held parallel to the body, while the wrists are flexed. Now, subarachnoid hemorrhage will also cause increased intracranial pressure. So, increased intracranial pressure also leads to Cushing's triad. Cushing's triad consists of raised blood pressure, that is hypertension, decreased heart rate, that is bradycardia, and irregular respiration. Now, the subarachnoid hemorrhage are also characterized by seizures that can be focal seizures or generalized tonic-clonic seizures. Then several stroke syndromes depending on which part of the brain is affected. The numbness, sudden muscle weakness, slurred speech, vision problems. An important mnemonic to remember is FAST. F stands for facial drooping, A stands for arm weakness, S stands for speech difficulties, and T means time, that is to get help quickly. Now, based on the clinical presentation of subarachnoid hemorrhage, a Hunt-Hess scale has been devised. It basically determines the risk of mortality in patients of subarachnoid hemorrhage. Grade 1 patients have minimum risk of mortality, while grade 5 patients have maximum risk of mortality. Coming to the diagnosis of subarachnoid hemorrhage, a non-contrast CT scan shows hyperdense white matter in the various sulci, cisterns, and the different ventricles of the brain. The modified Fisher scale, based on the findings of a non-contrast CT scan, determines the risk of vasospasm. There are various gradings, grade 1, 2, 3 and 4. In grade 4, thick subarachnoid hemorrhage greater than 5 mm plus intraventricular hemorrhage, it shows that there is a high risk of vasospasm. So grade 1 shows the minimum risk of vasospasm, while the grade 4 determines the maximum risk of vasospasm. Now, after the non-contrast CT scan, CT angiogram will help to identify the vessel aneurysm and will also help to distinguish reversible cerebral vasoconstriction syndrome or the Cole-Fleming syndrome. Digital subtraction angiography is the gold standard for the diagnosis for subarachnoid hemorrhage, as it helps in actual visualization of the vessels. However, it is an invasive procedure. Now, in patients of subarachnoid hemorrhage, a non-contrast CT scan has high sensitivity in the first 24 hours. However, as the time progresses, a non-contrast CT can be negative. So, in patients where non-contrast CT is negative, but there is high suspicion of subarachnoid hemorrhage, then a lumbar puncture can be performed. The test tubes are filled with blood. In fresh hemorrhage, all the test tubes will be red, while in older hemorrhage, there will be xanthochromia or the yellowish discoloration. The redness of the test tube can either be due to subarachnoid hemorrhage or due to traumatic tap. Traumatic tap basically means injury during the lumbar puncture procedure. So how to distinguish between a subarachnoid hemorrhage and a traumatic tap? So in subarachnoid hemorrhage, if we fill all the three test tubes, all the tubes will remain uniform pink, while in traumatic tap, the last test tube will become clearer. Then clotting will not occur in subarachnoid hemorrhage, while it will occur in traumatic tap. In subarachnoid hemorrhage, the clotting does not occur because of defibrillation. In subarachnoid hemorrhage, the color of the supernatant fluid will be xanthochromic, while in traumatic tap, it will be colorless. Now, the management part of the subarachnoid hemorrhage starts with ABC, that is maintaining airway, breathing, and circulation. Now, why maintaining airway is important in patients of subarachnoid hemorrhage? As we all know that the increased intracranial pressure can cause herniation, and the herniation can compress structures in the brainstem which holds the respiratory center, so it can affect the breathing. So intubation is important, and it's specifically indicated when the Glasgow Coma scale is less than 8. It can be done through controlled mechanical ventilation and assistant support ventilation. Then blood pressure control, that is maintaining circulation, is also important. The desired goal should be less than 160 mm of Hg. We give nicardipine, that is a calcium channel blocker. It is basically a vasodilator. Then labetalol, alpha plus beta blocker. It will decrease the inotropic and the chronotropic effect and will also act as vasodilator. Then hydralazine is a vasodilator. It will reduce the afterload. And enalapril, which is an AC inhibitor, it acts as a vasodilator which will reduce the preload. Then external ventricular drainage is also required. Is used to drain the blood from the ventricular system. The indications include a high Hunt-Hess score and obstructive hydrocephalus. If the clotting occurs in the ventricles due to intraventricular hemorrhage, intrathecal tissue plasminogen activator is given. It also helps to control intracranial pressure. For sustained intracranial pressure greater than 20 mm Hg, the neck must be in midline as it helps to promote venous drainage. Then head of the bed should be at 30 degrees, and then we can give mannitol and hypertonic saline which helps to promote brain shrinkage. In the surgical intervention part of subarachnoid hemorrhage, coiling and clipping procedure is most commonly used. In coiling procedure, a catheter is inserted into the aneurysm and coil is released into the aneurysm. After the coil fills the aneurysm, the catheter is removed. In the clipping, vascular clips are applied over the neck of the aneurysm. Now, where to use coiling and where to use clipping? So several factors are there which helps to determine in which patient coiling should be preferred and in which patient clipping should be preferred. So in older patients, coiling is generally preferred, while in younger patients, clipping is preferred. Clipping is also preferred in hemodynamically stable patients. The neck of the aneurysm also determines whether to use coiling or the clipping. If the neck of the aneurysm is small, then coiling is preferred. If the neck of the aneurysm is large, then definitely coiling cannot be used because the coil will fall back into the artery. So if the neck is large, clipping is generally preferred. Then location of the aneurysm also determines whether coiling and clipping has to be done. Clipping is preferred in aneurysms of the middle cerebral artery, anterior cerebral artery, and in the internal carotid artery, while the coiling is preferred in aneurysms of the vertebrobasilar system. Now, an important cause of high mortality in patients of subarachnoid hemorrhage is the rebleeding of aneurysms. So, of course, we have to either revise the clipping or the coiling procedure, but before clipping and coiling, the fibrin mesh has to be stabilized through aminocaproic acid and tranexamic acid. However, caution has to be exercised in patients of ischemic heart disease as it can lead to clotting. Then cryoprecipitate has to be given. Now, vasospasm is commonly seen in day 4 to 14 of subarachnoid hemorrhage. Due to vasospasm, the vessels become stenotic, affecting the blood flow through them. Now, how to monitor the vasospasm? It is done through daily transcranial Doppler. As we all know that in vasospasm, the vessels become stenotic, so the diameter of the vessel will decrease. When the blood passes through a smaller diameter, the velocity will be relatively higher. So in middle cerebral artery, if the velocity is greater than 120 centimeter per hour to more than 200 centimeter per hour, it is highly suggestive of vasospasm. Another important parameter to measure the vasospasm is the Linde-Gaert ratio, which measures the mean flow velocity in the middle cerebral artery to the mean flow velocity in the internal carotid artery. If the ratio is between 3 to 4.5, it is suggestive of mild vasospasm. 4.5 to 6 suggests moderate vasospasm, and if it is greater than 6, it is suggestive of severe vasospasm. Treatment of vasospasm includes relaxing and dilating the vessel, that is, we give nimodipine, it is a calcium channel blocker, and then we give intraarterial dilators like milrinone and nifedipine.